So what I want to do is take us back here really quick and have us review those functions. How do we accomplish those basic functions, all right, in the kidney tubule? And my drawing here is pretty good in the sense that it reflects the difference between the afferent arteriole and the efferent arteriole. And what do you see the difference is? Smaller diameter in the efferent arteriole, and what's the consequence of that? You build up some hydrostatic pressure, which allows for the first event, which is filtration. And in that filtrate, you produce, among other things, a bunch of wastes, or you press the wastes across the filtration barrier, right? Describe the filtration barrier for me. Describe the filtration barrier for me. The filtration barrier is the capillary endothelial cells, which are cells of the glomerulus, right? And the visceral layer, which is the podocytes with their pedicels. Very good. All right, and that's the filtration barrier, and we press across a filtrate of the blood plasma, minus proteins, minus cells, but it includes a bunch of goodies and cellular wastes. And if we leave those cellular wastes in the kidney tubule, they will be excreted, right? Check. Number one, done, right? All right, number two, regulating body fluid volume, okay? And where does that take place? In the collecting duct. That's the right answer, all right? I was waiting for some of you to step into the big rusty bear trap and say the Loop of Henle, and you know that wouldn't be right. But instead, it takes place at the collecting duct, all right? But it's made possible by the Loop of Henle, isn't it? All right? And give me two things that the Loop of Henle does that allow you to regulate body fluid volume. It forms a sodium concentration gradient. Very good. All right, it forms our concentration gradient, which we're going to use if we need to concentrate the urine in the face of dehydration. All right, and by the time the filtrate gets to the top of the ascending limb, it's hypotonic. It's only 100. All right, instead of 300 like the blood plasma, right? In other words, it's more dilute than your blood plasma. And that means if I allow it to pass through the rest of the tubule unaffected, I'm going to be able to get rid of more water than salt, right? I'm going to be able to lower my body fluid volume in the face of overhydration. I'm going to be able to produce a dilute urine. So the Loop of Henle does two things. It created this salt gradient for us, and it dilutes the filtrate down to the level of 100 versus 300. Okay? And if we leave it in, then we're going to excrete. All right? What if you're dehydrated? What happens if you're dehydrated? Start up in your brain. You're dehydrated, so your cerebrospinal fluid and your blood plasma become hypertonic. Go ahead, good. That causes... No, you're getting it now? That causes the osmoreceptors to shrink, all right, because it's saltier outside than inside, right? So they're going to shrink, okay? And that in turn results in the release of ADH from the posterior pituitary, all right? And that circulates, and where does it have its action? Where does ADH have its action? ADH has its action on the collecting duct. And what is its action? It's going to increase the permeability, right on. Increase the permeability of the collecting duct to water, right? And that water is going to be drawn out, all right? And where's it going to go? Back into the body. How's it going to get there? Via the Via the vasa recta. Okay? Via the vasa recta. What's the vasa recta? No. Yeah. Yeah, amazing. Huh? What's the vasa recta? You can consult your neighbor if you want. Yeah. What's the vasa recta? It's the capillaries that surround the loop of Henle. Okay? It's the capillaries that surround the loop of Henle. And the reason I mention it is that you have this capillary going down like this. Check this out, you guys. Sorry to pick on you there, but it's good. Pay attention, all right? So you have this capillary that's an extension, right? We've got our peritubular capillary network here, and we have an extension going like this. Where are we in the kidney in terms of gross anatomically when we're down here? We're in the medulla, right? Where's the hilum of the kidney? Down here, isn't it? And you've got a capillary going down here. Why doesn't that capillary just converge into a vein and exit the kidney? Why does it bother to come back up again and then eventually give you the... Yeah, well, it's passing passing along here, all right? And so you have capillaries going down. Remember, this is all collected together here, you guys. The reason is because if it did this, all right, what's happening to the blood plasma here? This is 300, right? And this is 600 out here, right? So salt can be getting into the blood here, right? As it goes down, salt can be getting into the blood here. And if it continues on down, where do you think all that salt is going? Back into the body. But if the vasa recta turns around and goes back up here, the salt that came in here goes back out there, and you don't dismantle your gradient. How cool is that? All right? You don't end up dismantling the gradient, but you do end up picking up all the water that's sitting there. All right? And that water goes back into the body. Okay? So we've been able to regulate body fluid volume, all right, via the actions of ADH or the diluting of the filtrate, all right, thanks to the loop of Henle. All right, what's happening in the proximal tubule? Reabsorption. Most of the reabsorption, 80% plus of the reabsorption is taking there. And in what manner is reabsorption taking place? It is equal water and solutes, meaning it's isotonic. All right, which means that you're not changing the filtrate in terms of its concentration. You're simply reclaiming a lot of stuff. All right, all the goodies that are in there, and you're putting them back into the peritubular capillaries. Okay. All right. Third function, regulating ion concentration of the body fluids. That takes place here, right, in the distal tubule, with the help of receptors in the adrenal cortex, the adrenal gland, all right, receptors in the adrenal cortex that are sensitive to a drop in sodium, all right. If you have a drop in sodium, what's going to happen to your blood pressure? If you have a drop in sodium, your blood pressure is going to go down. That's not good, eh? All right? So you have a drop in sodium levels. The adrenal cortex is going to secrete aldosterone, all right? And aldosterone will circulate, and it will have its action here on the distal tubule. And what's its action? It's the action of aldosterone. Bring about, come on you guys, reabsorption of sodium and secretion of potassium, right? And that restores that balance between the inside and the outside of the cell. Go ahead.
When you say the adrenal cortex, are you talking about the adrenal gland that is located near the kidney?
That's the only adrenal I know.
Okay. I didn't know.
Yeah, that's the only one.
Okay.
Yeah, you bet.
Even though it's a little bit, sometimes it's not necessarily located on the kidney. It still can get it connected somehow.
These are hormones.
But the gland itself.
The gland is there, but these are hormones, right?
Hormones.
You didn't worry about ADH getting to the kidney, released up here. Okay? All right. You put it in the circulation, it circulates, and then that's its target. Okay? And there are other targets as well. All right? Guess what else aldosterone does? It causes vasoconstriction. It's acting on your arterioles throughout the rest of the body to constrict, which is going to do what to blood pressure? It's going to raise blood pressure. So these things have dramatic effects, widespread effects, which is one of the key features of hormones, right? Is that they can have widespread effects versus what's the other way that your system communicates? Nerves. Nerves, right? And nerves don't have widespread effect. They have targeted effects, right? I just want this muscle operating, right? Okay. What if I used a hormone to do this? I'd be, right? Okay. All right. Okay. So, what do you think this epithelium looks like here? Simple columnar, lots of microvilli, right? Because this is a lot of absorption, right? And there's a lot of uptake of things, so you need a lot of mitochondria, all right? So this has a lot of microvilli. This, on the other hand, doesn't. So if you look at a cross-section through the cortex, you're going to see cells here. There is an image, but it's not worth looking at, really. Here it is. No, that's a cross-section through. I don't have it on here, you guys, because I just put some of the slides on. But you have microvilli here. You don't have microvilli here because there's not a lot of reabsorption taking place there. You're just regulating ions there. Okay. It is simple columnar, but it just very few microvilli. All right. And so when you look at it in cross section, you can actually see that little band of stain that indicates to you that there's microvilli there. You can't really see them through your light microscope, but you know they're there. Like when you look at the intestine, you see a little band that you go, oh yeah, that's microvilli there. Right? Likewise, here you see it in the proximal tubule, but you don't see it in the distal tubule. Okay? All right. That's... Yes? Simple cuboidal. All right, I'll take cuboidal. That's fine. All right. With microvilli. Yeah, thank you. Okay. All right. That's the important piece is the microvilli. Yeah, you're right. You're right. Cuboidal is more correct. Good.
Dr. Deven, the vasorecta is just invested with juxtamedullary nephrons.
That's right. So the vasorecta is there again. It's paralleling the loop of Henle of those juxtamedullary.
For it to do any type of reabsorption or anything for the cortical nephrons, then it happens just from that same.
That's right. That's right. That's right. So you have a bunch of capillaries that are dipping downwards, all right? And, to draw them like this is sort of to mislead you, isn't it? Because they're really picking up what's happening here. And it's useful for you then to go back and look at these images here of the tubule, which even these aren't that great, that show you that it's not as spread out as I draw it. All right, I draw it so you have all the elements are sort of spread out, and actually they're all really pressed into that renal pyramids. Okay, all right. So I think we're pretty good on these different regulation elements here. Let's move on, you guys. And where I wanted to go was just to finish up talking about the rest of the urinary system, and what's left is for us to look at these two paired fibromuscular tubes. Here you see them, the ureters, all right, the ureters extending down from the hilum of the kidney to the posterior side of the bladder. And then we'll talk a little bit about the urinary bladder itself, and then the urethra, the final path for urine, okay, for excretion of urine. All right, and the ureters themselves, retroperitoneal, 3 layers instead of our 4 tunics. All right, there's only 3 tunics here, as I indicate. You've got a mucosa that's transitional, and not to be too personal with you guys, but how many? This is personal. Sorry. All right, you just empty your bladder, and you're not 10 steps out of the bathroom, and all of a sudden, maybe I didn't just empty my bladder. I thought I did, but, well, the renal pelvis receives fluid, and it compresses to drive that down through the ureters, all right? But it's a pulsatile thing, and so it can be filled, but it hasn't arrived to your bladder yet. And then it undergoes one of its regular kind of compressions, and all of a sudden, I thought my bladder was empty, but it isn't empty now, all right? And so that's because both the renal pelvis and the ureters actually hold urine, and then they compress to drive that urine down into the bladder. All right. So we have a mucosa that's transitional. All right. And as soon as you hear transitional epithelium, that's what maybe tell you about that. As soon as you know it's transitional, what does that tell you? That it's able to expand. Right. That's able to expand. The bladder, of course, is transitional epithelium as well. The ureter's transitional epithelium. You even have these folds. So when we look at the ureter in cross section, you see it's highly folded like this, and that means that it's capable of expansion. All right. So this is the mucosal layer, dense irregular connective tissue with a mucosa, as we've said, of transitional epithelium. Outside of that, there's no submucosa. Instead, we go right to the muscularis, and it is opposite to what you learned in the digestive tract. Instead of inner circular, outer longitudinal, it is inner longitudinal, outer circular. All right, and this is going to drive the urine down into the bladder by peristalsis, which is what my comment was of a moment ago. All right, it isn't gravity flow. All right, it's driving it down by peristalsis. And then finally, because it's retroperitoneal, you don't have a serosa. Instead, you have, again, an adventitia. All right, an adventitia. All right. The urinary bladder, of course, is a reservoir, and it too sits retroperitoneal. And I guess a common misconception that I have probably conveyed to you is the idea that anything that's retroperitoneal must be on the dorsal body wall. I didn't convey that, did I? Well, maybe if I did suggest that, you know it's not true. It just means that it sits between the peritoneum and the body wall, so it isn't completely invested, it isn't completely surrounded, right, by peritoneum. And in this case, the bladder, of course, sits anteriorly, all right. But it is then, by definition, retroperitoneal, all right. The openings for the ureters approach the bladder posteriorly, and they enter obliquely. And the reason is, if they enter obliquely, meaning they enter into the bladder at an angle, it means that when the bladder is full, it closes off access, so you don't get any refluxing. You don't get urine moving backwards up the ureters. All right, as the bladder fills, it's essentially sealing off access into the ureters. All right, to prevent it from backflow. All right, and we define this little smooth region. All right, of the urinary bladder that's different from the folded walls. You know, whenever you have these folds, these rugae, all right, it's telling you again this is a vessel that can expand like your stomach. All right, has those same rugae. All right, and all of the bladder has that folded pattern except this little region here, which is a triangle formed between the connection points of the ureters and the beginning of the urethra, all right, the exit point of the bladder, and that forms this little triangle, which is called the trigone, all right, the trigone. And the bladder itself, 3 muscle layers, all right. Let's look at the mucosa first of all. All right, you have again transitional epithelium in the mucosa. You do have a submucosal layer of dense irregular connective tissue, and then you've got smooth musculature in 3 layers forming what's called the detrusor muscle, right? And the detrusor muscle is smooth muscle that's able to contract and helps you to empty your bladder, right? And so this is smooth muscle layers again under the control of your autonomic nervous system, right? And as I've begun to sort of teach you, and we'll get into it specifically later, but again, with the autonomic nervous system, we talk about what the parasympathetic branch, which is rest and rumination, all right, basic body functions, all right, and the other side is the sympathetic branch. It has sympathy for you during times of stress, also known as the fight or flight, all right, and that's the sympathetic branch, okay. So what do you think triggers the compression or the contraction of these smooth muscles, the detrusor muscle? Sympathetic or parasympathetic? Parasympathetic. You're not going to empty your bladder in times of stress, all right? You're going to empty it when you're relaxed, right? All right? Is that okay? And conversely, though, the detrusor muscle at the base of the bladder, all right, forms the internal urethral sphincter, all right? So this is your internal sphincter. It is just a thickening of the detrusor muscle that forms the access point, or the origin, rather, of the urethra, all right? And what do you think relaxes that muscle? That's also parasympathetic, all right? So parasympathetic is causing contraction of the detrusor, but it's causing relaxation of the internal urethral sphincter. Again, that's an involuntary smooth muscle sphincter, all right? As you know, you also have an external urethral sphincter, and we'll get to that one in just a second. Yeah.
In lab, the different bladders that we saw, there were like significant differences. Does that detrusor muscle actually change in size as well, or?
Significant differences? You mean in the preserved specimens that you're looking
The
at?
cats that we, yeah. Like a full bladder was pretty big, and another one was like that. It just seemed significantly different as far as if a muscle was there, it would have been hard to stretch that much, or?
You know, I don't know. I mean, I'm always leery of anything in a preserved specimen. All right, the preservation changes it a lot. All right, so things become bigger and more loosely configured than when they're live tissues and they're wet and humid, moist from their body fluids and so forth. But I don't know it's possible that when they fixed these things, some had a full bladder, so the bladder was distended, and then they put these fixatives in which cross-link all the tissues, and it stuck that way. And some the bladder was empty when they fixed it, maybe something like. Oh, if it's capable of those kinds of changes. I don't know in cats. In humans, as you can see in the images there on the right, you've got a pretty good volume change there, right? Pretty significant volume change. Okay, again, the bladder is retroperitoneal, so again you expect there to be a cirrhosis or an adventitia, except on the superior surface, right, where the peritoneum rides essentially over the back of and top of the bladder, all right, and where it covers the top of the bladder, you have the expected serosa there on the superior surface, all right. And the term that we use for emptying the bladder is micturition, all right, micturition. And again, it is a parasympathetic activity that involves contraction of the detrusor and relaxation of the internal urethral sphincter. All right. Now, coincident with that, you also have to relax the external urethral sphincter. So here again, you see the bladder. There's the internal urethral sphincter. Here's the urethra in a female. All right. Short urethra. Its only purpose is to empty the bladder, unlike in the male where the urethra has both urinary functions and reproductive functions. All right. And as the urethra passes through the urogenital diaphragm, meaning the musculature at the floor of your pelvis, of your perineum. Perineum is the floor of your pelvis, all right? As it passes through the urogenital diaphragm, that is skeletal muscle, all right? And skeletal muscle, of course, is voluntary, all right? So the external urethral sphincter is under voluntary control, and that is, again, that's the urogenital diaphragm, which we're going to come back to and talk more about later this evening. All right. The epithelium in the urethra changes. All right. It's transitional near the beginning because it's just a carryover of the epithelium from the bladder, and then eventually it changes into stratified squamous. in the female, that's pretty much it. In the male, it goes through about 4 different versions of epithelial changes, and I'm not too concerned about that. All right. All right. So that's in the female. In the male, again, the urethra serves both urinary functions and reproductive functions. And so if we again begin up here at the urinary bladder, we see the urethra first emerging from the bladder directly into the prostate gland. All right? And the prostate gland becomes a crossroads where you're going to have the vas deferens, the paired tubes that come from the testes that carry semen, all right, entering into the prostate gland as well, all right, and we're going to see that perhaps this evening if we get to it, all right, and they then converge into the prostatic urethra, all right, and from that point on, the rest of the urethra in the male is both urinary and reproductive, all right. We describe then the urethra in the male as the prostatic urethra, followed by the membranous urethra, which passes through the urogenital diaphragm, and this forms the external urethral sphincter in the male. All right, and then finally the spongy urethra, which passes through one of the 3 bodies of erectile tissue. All right, the corpus spongiosum, right, in the penis, that allows both drainage of urine and ejaculation of semen. Okay. As you note up here on the figure, the epithelium changes from transitional to stratified columnar to pseudostratified epithelium to stratified squamous, and why it goes through all of those versions, I don't know. All right, I can understand the transitional and the stratified squamous, but the others, I don't have any knowledge of why it does that. All right. So, well, you have, yeah. I think that should be pseudostratified columnar, but yeah, maybe that could be my own typo there. All right, or I'm just making it up. All right, yeah, it's probably my typo. All right, so with that, we're going to leave the urinary system. All right, and we'll come back and talk a little bit more about this anatomy as we look into the reproductive system.